The video recording, so just me?
I can't press because my computer's here.
Okay.
That's the problem. G'day everyone, and welcome to the GIT Part 2 revision lecture presented by Julien Nityanandan, featuring Gaussian Nageswaran.
I'll wait a few. Cool, thank you. It's very bright. Can we make it less bright? Awesome.
Damn. Hopefully that works.
Cool. Ready to go? Ready to go? Awesome. All right. Hi, everyone. Thank you for coming once again, and welcome to the second part of the GIT hepatobiliary lectures. Today will be, that's what we did last week, and that's what we're doing this week. So we're going to be going through lots of lower GIT. I'll be asking a lot more questions just because it's a smaller group, and we'll try to keep it as interactive as we can. If you've got any questions, feel free to yell out as well. All right, let's get straight into it. So on the pancreas, so a brief bit of anatomy. If you can, label some of the parts and the ducts in your own time. But a couple of questions for revision. Can someone briefly describe the exocrine and endocrine functions of the pancreas? Anyone?
Exocrine is like making the chyme into something more, like neutralizing the acid.
Mm-hmm.
So bicarbonate and stuff like that.
Yep.
And endocrine is like insulin and hormones.
Yep, exactly. Perfect, Charlie. The exocrine function has to do with the acinar cells, and they make that pancreatic juice, which contains those digestive enzymes, which is involved, which then goes to the duodenum and then, as Charlie said, works on the chyme. Whereas the endocrine part of the pancreas, the islets of Langerhans, containing the beta cells and the alpha cells. Alpha cells secrete glucagon, beta cells secrete insulin. Okay, so a bit of anatomy, and we'll talk about why that's significant later, with pancreatitis leading to diabetes in some cases. So referring to the anatomy, I'll answer this one. So how can cholelithiasis lead to acute pancreatitis? Last week we talked about cholelithiasis being the presence, lithiasis of stones in the biliary tree, specifically in the bile duct. So if you have a stone that's more towards the bottom end of the bile duct near the ampulla ovata, that can not only obstruct the biliary tree, but it can also obstruct the pancreatic duct, which is joining towards it. You get backflow of those digestive juices, digestive enzymes in that pancreatic juice, and that leads to autodigestion of the pancreas. Does that make sense? Awesome. All right, a few other things. So I'll just go through these. So the functions of, there's lots of pancreatic enzymes, but these are three main ones. So there's trypsinogen, which is a precursor to trypsin, and it's needed for protein digestion. Amylase, which breaks down starch essentially, and lipase, which breaks down fat. Lipase is highlighted in red because it's significant in the context of acute pancreatitis. It can be elevated in lots of things. So peptic ulcer disease, small bowel obstruction, cholecystitis. Often a lot of abdominal pathology will give you an elevated lipase, but specifically acute pancreatitis. Does anyone know what limit or what level of lipase you'll see? Yeah, it's generally, yeah, whoever said that, generally 3 times or more. Okay, so that's a bit of anatomy of the pancreas. In terms of acute pancreatitis, it's a disorder of the exocrine pancreas, as we talked about before. So acinar cell injury with accompanying inflammation. It can be acute or it can be chronic. So with chronic pancreatitis, you generally get progressive disease, scarring and fibrosis. And it's often generally due to alcohol and years of chronic alcohol consumption. You can generally pick it in a clinical setting. In terms of etiologies of acute pancreatitis, I get smashed is a nice mnemonic, but by far the majority of causes are alcohol and gallstones as well. In terms of presentation, most of it's on the slide, so epigastric pain radiating to the back, can be an obstructive jaundice picture as well. You can see signs of hypovolemia, signs of retroperitoneal hemorrhage. There are 2 specific signs on an abdominal exam. Anyone know what I'm talking about? Yep, excellent. So Cullen's around the umbilicus, or a blue bruising around the umbilicus, and grey Turner's sign. again, blue bruising around the lumbar regions. So there's signs of retroperitoneal hemorrhage and signs of hypocalcemia. And I'll talk about why you get this a little bit later. Does anyone know some symptoms of hypocalcemia? That's hypercalcemia. Pardon? What were you going to say? Yeah, tetany. So tetany are symptoms. So CATS go numb is a bit of an acronym for symptoms. Convulsions, arrhythmias, tetany, and then S is for like spasm and seizures. N is for numbness, can be in the limbs, also generally around the lips. That's quite a good buzzword. And there are two signs to do with tetany. So Chopstick sign, so that's tapping over the facial nerve, and that can sort of lead to a facial twitching or a facial spasm, and Trousseau sign. So it's essentially where you inflate a blood pressure cuff on someone's arm and it leads to a carpopedal spasm where the hand kind of looks like this a little bit. So that's acute pancreatitis. In terms of investigations, it's all on the slides. Blood sugar levels, if you're worried about, chronic pancreatitis leading to a diabetes. Urinalysis, if you're looking for an obstructive picture. Everything else is there. So FBE, you might see a neutrophilia. CRP would be elevated. I guess UEC, if you're worried about an acute kidney injury, which can be a complication. And then you're looking at LFTs and coags. So LFTs could be, a few different pictures. If it's like an obstructive jaundice picture due to cholelithiasis, you might see an elevated ALP and a GGT. If it's an acute pancreatitis caused by like an acute binge of alcohol, you might only see an isolated spike in the GGT. Whereas it's, if it's something more like chronic alcoholism, you might see moderately elevated ALT and AST. Okay, so remember we talked about some of the different patterns of liver function tests last week. A few significant things with serum lipase and serum amylase. Serum amylase generally rises faster and has a shorter half-life, where serum lipase generally takes a few days to rise. So if someone's been sitting around at home and then only presents to the emergency department, there might not be much point in doing an amylase because it would have already risen. There are a few other tests there which we'll talk a little bit about later, and the spot diagnosis as discussed before are Gray-Turner's on the left and Cullen sign on the right for retroperitoneal hemorrhage. These are a few severity criteria for acute pancreatitis. The Ranson's criteria is performed on admission, and the Glasgow one is done generally about a couple of days later, and they kind of correlate with prognosis. That was supposed to become, I think I've clicked too far. Okay, anyway, forgot to animate that. But two reasons to check calcium levels. Hypercalcemia is a cause of acute pancreatitis, a rare cause, but it's still a cause. And hypocalcemia might be detected due to the disease process of acute pancreatitis. Does anyone know why you might see a hypocalcemia in acute pancreatitis? Just yell it out. Yeah. Yeah, saponification. Yeah, so pretty much what happens is you get like the leakage of a lot of these pancreatic digestive enzymes, and that can have a lot of effects on the body, one of which is it acts on some of the fat cells, and then, let me get this right. Yes, yeah, so the digestive enzymes work on the fat cells, then you get the breakdown into fatty acids, and those fatty acids combine to calcium. So the body says, hang on, where's all the calcium gone? And then you get hypocalcemia, when actually it's just bound. ERCP is a common investigation used in a lot of cholelithiasis and acute pancreatitis. It stands for endoscopic, because it's a scope. Retrograde, because you're going backwards. So you put the scope in, and then you kind of work backwards up the biliary tree and the pancreatic duct, and cholangio, biliary tree, pancreatograph, the pancreas. And it's pretty much you put the endoscope in the duodenum, and then you have a cannula which looks into two of those ducts, and you insert dye so you can look for blockages or any sort of obstruction. With ERCP, so it's both therapeutic and diagnostic, so it can also remove any gallstones that are there as well. In terms of management, you always start with your sort of conservative general abdominal management, so analgesia, making sure they're fluid resuscitated. If appropriate, they might need to have a nasogastric tube in or be nil by mouth. And then it's always important to treat the underlying cause. So with gallstones, you might do a cholecystectomy or you might do ERCP. If someone has alcohol-induced disease, anyone know what we might give them? Benzos, okay, so benzodiazepines generally. You might also have to look at vitamin and mineral replacement, thiamine in particular, as we talked about last week. With chronic pancreatitis, you might have to give them pancreatic enzyme supplements, possibly insulin as well, depending on how bad it is. Does anyone know the antibiotics we use in pancreatitis? I'll talk about when we use them in a sec, but does anyone know? There's 3 of them. So it's meropenem, piperacillin, and imipenem. Okay, don't ask me to say that again. It's difficult enough as it is. Okay, meropenem, piperacillin, and imipenem. Just Google antibiotics for acute pancreatitis, it's probably easier. But yeah, they're the 3 that are indicated, but they're not generally prescribed. They're only really indicated if it's severe, so like severe sepsis or you've got necrosis of the pancreas. Okay. Lots of complications, acute kidney injury. You can get a pancreatic collection, which is just, I guess, a sac around the pancreas of pancreatic enzymes. There can be a bit of blood and fluid, and that can lead to a pseudocyst, which tends to form in about 6 weeks. That's when you get the walling off of that collection. If that sort of collection, that pseudocyst can often compress other structures as well surrounding it. Pancreatic abscess is just if that colonization gets infected. Pancreatic necrosis is quite straightforward. It's necrosis of the pancreas. That's when you might have to look at surgical intervention to remove some of the parts of the pancreas. There are some vascular complications and also pancreatic insufficiency, which we're going to talk about next. So, chronic pancreatitis. Yes. I don't know of the mechanism, but I know there is a few there's a splenic artery aneurysm, splenic vein thrombosis. I'm not sure how, but there's a few complications there. Good question though. Sorry, I couldn't answer it. Chronic pancreatitis. So the 2 major sort of manifestations are the abdominal pain and pancreatic insufficiency, which can be further broken down. So in severe kind of exocrine pancreatic insufficiency, you've got decreased activity of those digestive enzymes. And as a result, you have decreased activity and also reduced release of those digestive enzymes into the duodenum. And as we talked about before, we need those enzymes in the duodenum to help break down chyme and things like that. So you've got less of those enzymes moving from the pancreas into the duodenum. The problem with that is it doesn't break down your fat as well. So fat, which should have been generally broken down, goes and passes onto the stools. So you get fatty stools, or in other words, steatorrhea. So steatorrhea is just defined as sort of greasy, oily, floating stools that are often difficult to flush, generally due to that fat. Okay, so that's because, due to the inability to absorb that fat. As a result, you can also get deficiencies in some of your fat-soluble vitamins. Okay, so that's if you just look at this question. So cystic fibrosis is kind of the next step. So in cystic fibrosis, you have a lot of mucus. Sometimes you can get a lot of that mucus in the pancreatic ducts as well, which is a different cause of pancreatic insufficiency. But it's the same process. You're unable to get those enzymes out to break down the fat. And you can notice in this patient, her vitamin D levels are low, despite getting supplementation. And that's due to her inability to absorb those fat-soluble vitamins, vitamin A, D, E, and K, into her system. It can also lead to, later on, another kind of, which kind of makes sense. This is related to what we talked about, the exocrine and the endocrine functions. So remember, the exocrine function is to do with the digestive enzymes. Over time, if you erode the exocrine pancreas, what's left is the endocrine pancreas. And if that becomes severe enough, it can lead to diabetes. Okay, and someone might need insulin for that. Okay, so that's essentially pancreatitis. All good? Awesome. All right, just a few key points for pancreatic cancer. So they're generally located, well, most of them, about 2/3 are located within the head of the pancreas, which is sort of significant clinically because it can lead to an obstructive jaundice from that extramural, it's an extramural cause of jaundice from that compression. It's often diagnosed at a very advanced stage. So it's, when someone has pancreatic cancer, it's a very poor prognosis generally. You have your generalized presentation. There's a few other things like Courvoisier's sign, which is a painlessly distended gallbladder. It's the fact that it's painless makes the pathology less likely to be gallstone, so you need to treat it with high clinical suspicion of being a cancer. And there's something called Trousseau's sign of malignancy, which is a paraneoplastic syndrome of pancreatic cancer. Do we know what a paraneoplastic syndrome is? Does anyone not know what it is? Okay, good. I'll assume everyone knows what it is. So Trousseau's sign of malignancy is migratory superficial thrombophlebitis. There was a guy called Dr. Trousseau who kind of saw a lot of his patients coming in with this sort of inflammation of the veins in the legs and different parts of the body. And then he sort of found this link between people developing this condition and then later on going to develop pancreatic cancer. No one believed him, and then one day himself actually developed these migratory superficial thrombophlebitis. And he says, I will die of pancreatic cancer. Of course, he actually did die of pancreatic cancer, and then everyone believed him. So there you go. That's a little story behind that. But yeah, so it's a paraneoplastic syndrome of pancreatic cancer. So just because you have this doesn't mean you will develop pancreatic cancer. But, you know, if you see this, you might say, oh, okay, that's worth investigating or keeping an eye on you.
Is that the same Trousseau that did Trousseau's sign as well?
Possibly, or I'm not sure. There's a lot of Trousseau signs. In terms of diagnosis, imaging and tissue sampling, pretty much with any cancer, if someone asks you how can you diagnose it, you know, you start your clinical suspicion with their clinical symptoms, but really imaging and biopsy is where the money is. And there's a staging system for pancreatic cancer as well. In terms of management, I mean, you can try lots of things depending on the extent of the disease. So radiotherapy, chemotherapy, and some other things we talked about. Probably the main one you need to know is the Whipple's procedure, which is a pancreaticoduodenectomy. And it's often completed with a Roux-en-Y anastomosis. So they pretty much take a little bit of those organs there. So they take a bit of the gallbladder, a bit of the duodenum, a bit of the pancreas in one go, and then kind of make a nice anastomosis where the stomach, the bile duct, and the pancreatic duct join in the bowel at different places. No. But I think it's worth knowing a little bit about the major ones. So Whipple's is kind of a pretty big procedure. Roux-en-Y anastomosis is you probably wouldn't have to know about Roux-en-Y. It's just more for interest. But things like cholecystectomy, colonoscopy, you know, they're very kind of big, common procedures. Maybe hernia repairs. Just know a little bit about each. You probably won't be asked. It's more kind of for knowledge on the wards. You might be asked a little bit about it in your OSCEs, but apart from that, it's not a high yield area. It's more kind of to supplement your understanding. Okay, that's the pancreas. So moving on to the small intestine. So hernias. So it's nice to have a nice tight definition of all these conditions. So a hernia is the protrusion of a viscus, generally bowel in this case, through a weakening in the abdominal wall, more common in males, indirect, more common than direct. Lots of risk factors there. In terms of classification, does anyone know how we classify hernias? So there's complete and incomplete. Pardon? Yes, that's very true. That's what I'll be classifying on the next slide. Yeah, very true. So there's complete and incomplete is one way of classifying it. So that just refers to how much of the hernia is protruding through. Is it the whole loop of bowel or just a partial protrusion through a defect? There's also incarcerated and strangulated. So incarcerated just means trapped or it's irreducible. So it's kind of like stuck. It's being stuck. It's, you know, I think about it a bit like incarcerated means you go to jail, so you're trapped. It doesn't necessarily mean strangulated. What's the difference? What does strangulated mean? Yeah, essentially compromise of vascular supply, okay? So there's complete, incomplete, incarcerated, and then strangulated. So yeah, strangulated, compromise of vascular supply. In terms of hiatus hernias, so there's a sliding and a paraesophageal hiatus hernia. So in terms of the types, so with type 1, a sliding, you get the gastroesophageal junction, which is labelled in the picture, along with the body of the stomach above. Whereas with the rolling one, it's just kind of the fundus of the stomach that kind of pokes its way out of the hiatus. Sliding is much more common. Generally with sliding, because you have the involvement of the gastroesophageal junction, you can get gourd-like symptoms. So we talked about that last week. What are some gourd symptoms? Anyone? Yeah, so heartburn, burning epigastric pain, water brash, regurgitation, burping, belching, those sort of things. But they can just as easily be asymptomatic, like rolling ones. Complications associated with GORD, obviously, Barrett's esophagus being one of the main ones, and complications with rolling. You can get sort of the twisting of the fundus around, causing strangulation and later on ischemia. In terms of treatment, it's mainly similar to GORD. So we start with lifestyle intervention, reduce smoking, hot and spicy foods, alcohol, that sort of thing. Medication, so a proton pump inhibitor. And then with surgical, so Nissen fundoplication, which we talked about last week, where we wrap the fundus around the esophagus to sort of reinforce the lower esophageal sphincter. With a rolling one, surgery is a much higher priority. So pretty much they poke the fundus of the stomach back down through the esophageal hiatus. They might consider also doing a Nissen fundoplication. And they also kind of make the hiatus a bit narrower by using some mesh. So otherwise we'll just come back up again. Yeah, so they're the two different types of hernias, hiatus hernias. Okay. Inguinal canal, bit of anatomy. So it's a slit-like passage, so going this way, and it moves from the deep inguinal ring, sorry, to the superficial inguinal ring. In women, the contents aren't really significant, but in males, the contents are very significant of the spermatic cord. In terms of the anatomy, you can look over it in your own time, but this is probably, I mean, on my year 3 rotations last year, in terms of surgery and surgical anatomy and being quizzed on, like this is probably the highest yield question. All the surgeons go, tell me about the borders of the inguinal canal. I ask you over and over again, because hernia is a very common operation as well. So yeah, it's just really important to know it. Okay. So with inguinal hernias, presentation, so they can have it might be an obvious swelling in the groin, or you might have to ask them to cough in order to see it, often with discomfort during heavy lifting. You might also see the silk sign, which is a palpable thickening of the spermatic cord. So what was your name? What was your name? Eva? Yeah, because Eva said another way of classifying inguinal hernias is direct and indirect. So direct ones are acquired. So it's that weakening in the anterior abdominal wall in whose triangle? Hasselbalch's excellent triangle, which is the linea alba, the borders of the linea alba, inguinal ligament, and also the inferior epigastric vessels. Yeah, so this is acquired due to increased intra-abdominal pressure, weightlifting, all those kinds of things. Whereas the indirect inguinal hernia is congenital, more common as well. And it occurs, why does it occur? What fails to obliterate? What structure? Can you remember? Yeah, good, processus vaginalis. So it's because the processus vaginalis fails to obliterate and it remains open, and you can sort of see that where the arrow is forming, a loop of bowel can just keep going down. Yeah, so that's the two types of inguinal hernias. Small bowel obstruction. So lots of causes of small bowel obstruction. Shaving is a nice mnemonic to remember them all. But the ones I've highlighted in blue are the important ones to remember. Conveniently, they're also the first 3 letters of shaving, which is good. So hernias or incarcerated hernias, adhesions. Your typical exam question to do with adhesions is someone's had previous abdominal surgery and stricturing. So with any kind of classification, intraluminal, intramural, extramural is good. Intraluminal, so intersection, that's just when a part of the intestine invaginates into the same piece of bowel. So just kind of bowel within bowel. What population would you see that in? Pediatrics. Yeah, exactly. Pediatrics, infants generally. Gallstone ileus we touched on last week as a rare sort of complication with cholecystitis. So it's where you get that cholecysecto entero fistula. There's essentially a connection between the gallbladder and the bowel. Rarer causes. Intramural stricturing can be due to any sort of inflammatory condition. Inflammatory bowel disease, Crohn's in particular, can cause stricturing. Extramural, so adhesions. So it's just kind of like fibrous scar tissue that tends to form after surgeries. It's kind of a bit of a paradox because in order to get rid of them, you have to operate as well. So it's kind of this vicious cycle. Incarcerated hernias, we talked about becoming trapped. A volvulus, what's a volvulus? Yeah, twisting of the bowel along its mesentery. Generally in small bowel obstruction, you can see a cecal volvulus. Large bowel obstruction, it's more a sigmoid volvulus, which is a significant cause of large bowel obstruction in developing countries as well. And then, of course, cancer as well. But cancers generally don't cause small bowel obstruction because the small bowel is very mobile and is able to move around. In terms of treatment, conservative as always. So here's where a nasogastric tube is really important, particularly if you're trying to decompress a bowel due to an obstruction. Correct the underlying etiology. Yeah, so, do they need a hernia repair? Do they need a part of their bowel removed due to a neoplasm? And then, yeah, so you generally wait a while and then you would consider surgery if it's unresolved. In terms of large bowel obstructions, some are similar. A lot of the causes are similar. It's just sort of the incidence which changes. So colorectal cancer is I would say it's the most common cause of large bowel obstruction. Sigmoid volvulus and also gynae causes as well. So endometriosis, which is essentially just where the endometrium, so the lining of the uterus, grows outside the uterus. So it can grow in sort of, the fallopian tubes or the ovaries, and sometimes it can go into the bowel. So that's small bowel obstruction. And there are some nice pictures. So the top left picture is of intersusception. The top right is, I think, an adhesion. Yeah, an adhesion. So you can see how it's causing. So you can sort of see how all these can cause kind of compression or an obstruction of the bowel as well. Okay, so appendicitis. I don't think it's going to work. Okay, it is. I'll just ask you the questions, put them up because my animation's stuffed up. Bit of anatomy if you're interested. So what's the trigger of acute appendicitis? So I put fecalith before. So what's a fecalith?
Impacted feces, essentially.
Yep. Yeah, so hardened stools or impacted feces. So what happens is you've got an obstruction in the appendix. The lumen of the appendix starts to fill with mucus. There's an increase in pressure, and then bacteria start to multiply. Over time, that increase in pressure can have an effect on, I think, the venules. They can thrombose. And because you're not getting appropriate drainage, you can get perforation, which can lead to peritonitis and sepsis and things like that. So that's generally the trigger. At which point is tenderness typically elicited? McBurney's, where is McBurney's point? Other way around, yeah. So it's just more closer to this side. So it's a third from the ASIS and 2/3 from the umbilicus. Rovsing sign, what's Rovsing sign? Not quite, but you can see rebound tenderness in peritonitis, yeah? Yeah, exactly. Good, what was your name? Edmund, yeah, Edmund's right. So it's palpation of the left iliac fossa, eliciting pain in the right iliac fossa. There's a few other signs as well. So generally, sometimes in some people, the appendix can be in different positions. So I'll just put these up. So there's a psoas sign and the obturator sign. So the psoas sign, it's a bit hard to explain the sort of test you have to do without moving it. So just look it up. But the psoas sign indicates a retrocecal appendix, and the obturator sign indicates a pelvic appendix and pelvic appendicitis.
Sorry, what's the reason for how you get the?
I'm not sure of the mechanism. It could be. I'm not sure why left iliac fossa is specified. I'll look it up and let you know. And the last question I had was, what is a common differential diagnosis for appendicitis, typically seen in children? Yeah, excellent. Acute mesenteric adenitis. So it's often in children. You get inflammation of the mesenteric lymph nodes. It's really good if you get this in anoscopy to mention that diagnosis because it is quite common. And it typically follows an upper respiratory tract infection in children. So that's appendicitis. It can be, appendicitis doesn't have to be your sort of typical presentation as well. Not all cases, you've probably seen this in hospitals, not all cases have to be that generalized umbilical pain which then moved to the right iliac fossa. It can be very varied. I saw a patient today who just had generalized abdominal pain. He said, oh, might be on the left, might be on the right. No nausea, vomiting, he was febrile. So he was febrile on Friday. But then on Saturday and Sunday, he felt a little bit better, and now he was a little bit okay. So we weren't really sure what was going on, no changes in bowel habits. Popped him on the examining table. As soon as I did, he was a little bit tender all over the place. As soon as I did tested for rebound tenderness, he jumped off the table. So we came to the presumptive diagnosis of appendicitis and sent him off to the emergency department. Why do you think that he was very bad on Friday, and then suddenly on Saturday and Sunday and Monday, he was a little bit better? Any ideas? Okay, so what we suspected was he might have had an inflamed appendix, and it was really pushing on the peritoneum. And then on Saturday or Sunday, it might have burst. And because there was no longer that pressure on the peritoneum, or it was a little bit less irritative, but there was still a pelvic abscess. Because it was less irritative, that's why there might have been a resolution of symptoms. But obviously, he's still unwell because there's all this gunk in his abdomen. So that was, what we came to the conclusion. But yeah, just keep in mind that appendicitis doesn't always have to be a, umbilical pain moving to the right iliac fossa. Okay, so just something different. So in terms of consenting, we'll talk about colonoscopy and a digital rectal exam, which are highly likely to come up in your OSCEs. With any explanation or consenting station, these are a few good tips. So always start the consultation, consent, confidentiality, Always ask, so what's your understanding of this procedure? You get an extra mark, and it helps kind of segue your response. Delivery of information, small chunks, summarize and repeat. Another good one is to advise them of any reasons they need to return to hospital. So for instance, with a colonoscopy, what might be some reasons someone might have to return to hospital? Pardon?
If they find something.
Oh yeah, so I mean like, okay, so what it was, fair answer. The patient themselves comes to hospital. So if they've got a fever, if they notice, significant, it's not uncommon to get a bit of bleeding after colonoscopy, but if you're getting significant bleeding for a number of days, that might be a reason to come to hospital. Or if you've got, if you get really low blood pressure, or if you're about to faint, you might be worried about a bowel perforation or something like that. So it's always good to advise patients of that. Leave time for questions at the end. According to my structure, I go benefits and then risks. So after you've talked about all the lovely risks of like bowel perforation and death, or probably won't mention death, they can go, oh, that sounds a bit scary. I don't really want a colonoscopy. But then you go, look, the benefits far outweigh the risks. And it's really important that we get this procedure done. So just some tips and a bit of a framework if you have to consent a patient in an OSCE. So in 1 or 2 sentences, can someone describe a colonoscopy or what a colonoscope is? Just very briefly. So what is it? What is a scope? Yeah, so it's a tube. It's a long, flexible tube with a camera. They'll be under light sedation, and we're going to put this camera on so there's a tube. There's a camera on the end of the tube. We'll pass the camera in the tube past your anus into your rectum, and then look around the rest of the colon, and we can just sort of explore if there's any sort of pathology there. So there's a better definition. So what else have I said? Yeah, so the scope can take pictures, and it can also remove lesions for analysis as well. Okay, so it's always nice to start with a nice succinct definition. Any medications which should be seized? I guess you could apply this to most surgical procedures. Anyone? Yeah, any anticoagulation? It depends. There's a few different guidelines for whether it's warfarin or a novel anticoagulant like apixaban, but generally sees anticoagulation about a week before. What are the logistics? So prior to the colonoscopy, what should someone do? Yes, fast. Bowel prep. It's also really important to mention that to them. It takes about 30 minutes to an hour. Length of stay, it should really only be a day procedure. If it becomes complicated, you might need a few extra days. And the anaesthetic is generally, you don't need a general anaesthetic usually. It's generally light sedation with a bit of pain relief. When you're asking about risks, always group it up into general risks and risks specific to a colonoscopy. BIFAP is a mnemonic someone told me for any general risk. So applies to most procedures: bleeding, infection. F is for failure, so failure of the procedure to, maybe this person has not taken their bowel prep and there's an inadequate view, so that's failure. A is like allergies or anesthetics, and P is pain. Okay, so there are always some good general risks you can start off. Specific risks to a colonoscopy, I've already mentioned one of them. I've mentioned two of them. What are some specific risks? Yep, bowel perforation, yeah. Yep, so bowel perforation generally is about 1 in 1,000. There are some other ones like some minor ones as well. So if someone might have a bit of discomfort due to the gas that's built up, or they might have some pain on defecating for a few days, not uncommon. Perforation, yeah, there's failure to view, a failure of inadequate view, often due to inadequate bowel prep. And then I guess long-term, we'll talk about that later. But yeah, they're the big ones. It's mainly perforation that's a big risk. Okay, so there are just some photos of varying degrees of preparation and varying degrees of good and bad bowel prep. And the bottom, some examples of polyps. So, sorry if you're eating pizza. All right, digital rectal exam. So what are some reasons we might do a digital rectal exam on someone? Pardon? Yep, prostate symptoms, yep. Speak up. Yep, PR bleeding, yep, good. So rectal bleeding, also unexplained anemia, especially in men, yeah. Anything else? Yeah, they're pretty much the main ones. There are a few other less common ones like anal pain and nerve supply as well. But yeah, it's mainly for rectal bleeding or unexplained anemia. I saw, this is not an uncommon situation. There was a 50-year-old man, came in very fatigued. That was his only presentation. Did a full blood examination, microcytic anemia. Did his iron studies, which were consistent with a microcytic anemia as well. Any trauma recently? No. You want any anticoagulants or anything like that? No. There were no any sort of malabsorption, Crohn, celiacs, anything like that? No. Obviously, he's a male, but otherwise we would have asked him about period habits and things like that. Yeah, so pretty much investigation, he needs a gastroscopy and a colonoscopy because there's a very high sort of suspicion of a GI bleed or potentially a cancer. Components of the digital rectal exam. So inspection, looking for things like, anal fissures, skin tags, hematomas, collections of blood, hemorrhoids. Can you see more obvious things like the bowel itself in a prolapse? Testing the anal wink or the nerve supply, asking the patient to bear down. Why might we do that? What might happen? Which would be bad. Oh, bad. Yeah, so fecal incontinence or prolapse. And then you do the perectal exam itself, getting them to squeeze finger and cough again, which is testing for sphincter tone, and then inspecting your glove for mucus and blood and stool and lovely other things. Okay, so with someone asked me to talk a little bit about OSCEs, so I'll do that briefly. So in a sample OSCE station might be you have 5 minutes to consent a patient and perform a digital rectal exam, and they'll have a model of a digital rectal exam and they might have a live patient there. You've got 5 minutes to do that. And then afterwards, the examiner will ask you questions for 3 minutes. Does that make sense? And these questions could very easily be questions that they ask you. So what are the indications? We'll talk about a few more questions later, but they could ask you like an emotional sort of question as well. So how would you respond to someone who says, I don't like the idea of a digital rectal exam. Can't you do something else instead? Any ideas? Just throw me some ideas of what you might say to that.
This is the least invasive test that we have. You can pick up a lot of stuff. The alternatives would be something much longer going in there. Yeah, good. Yeah, so I mean, like the alternative is, as Charlie said, we could go straight to investigations. But the thing about a PR is it gives you a lot of pertinent information very quickly. And it's also it's generally the first step in determining if you need more investigations down the line. So, if someone does a PR and everything's fine, you might not need to have a colonoscopy or something like that. So it can save you time and invasive procedures further down the line. Second, or maybe the same patient, I'm worried about experiencing pain during the exam, and sometimes I leak feces from time to time. So what would you say? Pardon? Won't say it on the recording then. Anyone else?
It's natural to experience some pain.
Yeah. Yeah. Perfect. So just allay their anxiety. A lot of this is common sense, but if you don't think about it, you might be a bit of a curveball in the OSCE. But yeah, so allay their anxiety. You shouldn't experience much pain. You might experience a little bit of discomfort, but nothing more than that. saying things like, leaking feces is a very, very common experience. We can set up the examination table. We can put some bluey wipes under there. So if it happens, it happens. But we won't make much of a mess. And yeah, so just kind of allaying the patient anxiety is a big factor here. A few other things. So what are some causes of a mass on a DRE? So what might you find? Yeah, enlarged prostate. Yeah, maybe colorectal cancer. Yeah. Anything else? So anything else with the rectum? What else might you find with the rectum? Yeah, potentially, yeah. Yep, so these are some of the ones I had, just grouping up between kind of organ, I guess. Yep, so it's also important to think about prostate, potentially a foreign body as well. Diverticular phlegmon, it's just kind of like an inflammatory mass with pus. Specific causes of pain during a DRE. Yep, anal fissures are very excruciatingly painful. Good. Anything else? So a thrombosed sort of hemorrhoid. So remember, any sort of ischemic pain is very severe pain. There's a few other ones as well. Contraindications. I mean, these are relative contraindications. Sometimes if you need to do a PR, you've got to do a PR. But yeah, mainly due to a pain. Maybe if it's an anal fissure and you don't think there's anything else, you can avoid it. In terms of reporting your findings, that's a good way of doing it as well. So talking about the tone, is it normal or reduced? I just go around the walls of the rectum. So anteriorly, could you feel the two lobes of the prostate with the midline furrow? Did you feel on the lateral sides any masses or any sort of lymph nodes, enlarged lymph nodes? And towards the back, talking about the coccyx as well, which shouldn't be normal. Which should be normal. If you find a mass, describe it. So where it is, consistency, all those kind of things, and then inspection with the glove. Okay, so moving along. So common presenting complaints. So Haematochezia. So we touched on this a little bit last week when we talked about hematemesis and melena as well. So something which I signposted last week. So a brisk upper GI bleed may also present as hematochezia. So whenever you're going through your differentials for lower bleeding, sort of bleeding in the stools, always think that it could be a very fast bleed coming from below. Fast bleed coming from above. There are lots of investigations. Okay, so 5 questions commonly missed when taking a history. I told you 3 of these last week. Does anyone remember what they were? This is really, really important. So when someone comes in with, there's blood in the toilet. Anyone remember from last week?
Is the blood mixed in or on the...
Important question, but these are kind of more, less gastro-related in a sense. Anyone remember? Okay, so hemodynamic instability, remember we talked about this? So assessing the severity of the bleeding just from asking the question. Have you fainted? Did you get, lightheaded? Asking if they're on any anticoagulant medications or have any bleeding disorders. These are really, really important. They're not going to cause bleeding itself, but it can exacerbate an existing cause. Have you had recent abdominal surgery or endoscopy? A simple question, but it can really give you the answer. A few other ones. Yeah, so the bleeding might not be from the bowel. If it's in the toilet, some patients might not have known where it's come from originally. Hematuria, probably unlikely. It's probably, males will probably be able to differentiate this a bit better, but females maybe not. So asking, is it hematuria potentially? Have you had any urinary symptoms? And also asking about, in females, if it's vaginal bleeding as well. So yeah, really, really important questions to ask when someone presents with bleeding from down below. Okay, in terms of etiology, so let's hear some causes of Haematochezia. Just shout them out. I've got 10 main ones. Yes? Yes, colorectal cancer, good. Pardon? Yep, so a brisk upper GI bleed, yep. Yep, inflammatory bowel disease, good. A few more. Pardon? Yep, diverticulitis. Unlikely. If could lead to ischemic colitis, yep. Yep, so post colonoscopy, post surgery. Yep, good, excellent, all very good ones. These are the 10 I had. We'll talk about most of these moving forward now.
But yeah, so it's handy to have these and ask some rule in, rule out questions as well. In terms of emergency management of shock, that's a pretty sort of basic way of looking at it, but it's good in your exams. If someone asks you, at the end of your history taking station, you've got 2 minutes to answer questions, someone presents with fainting and dizziness due to their loss of bleeding, what's some basic management? So gaining access to be able to take blood or give fluid and red blood cells, and then not forgetting about basic life support as well. Okay, so moving on to the large intestine. So a bit of revision. Layers of the GIT, especially in theatre, a lot of people talk about like the mucosa and the submucosa and then like the muscular layers and things like that. So just having this sort of, I thought this was a very good picture. Gives you a bit of context. So with the mucosa itself, so the innermost layer, it's split up into the epithelium, the lamina. So the epithelium has like, that's where like a lot of the absorption and secretion and stuff happens. Oh, sorry, not secretion, absorption and digestion happens. Lamina propria is CT, and then muscularis mucosa is a very fine layer of muscle. The next layer is the submucosa. So this is a lot of things. CT, lymphatics, vessels. It also has Meissner's or submucosal plexus, which is the motor or sensory. Pardon? No, Meissner's plexus. Secretory, yeah, secretory. So, yep, secretory. Then with the muscularis layer, so in the stomach, you have an additional layer, but generally it's a circle and longitudinal, and sandwiched between is the motor plexus or the myenteric plexus, and then you have the serosa, which is the outer layer. Significant in diverticular disease because you have these little herniations or outpouchings of the mucosa and the submucosa through areas of weakness in the colon. Which parts of the colon does diverticular disease tend to affect? Pardon? Yeah, sigmoid descending, sigmoid mainly, except in Asian populations where it's actually more, or I think it's relatively more common in the ascending colon. So there you go. So do people present with diverticular disease to hospital? They can. Anyone know what I'm alluding to? No? Okay. So it's kind of what we talked about last week, the infectious process. So diverticular disease is kind of like the broad umbrella term. Diverticulitis is inflammation and infection of one of those outpouchings. Okay? Does that make sense? So it's kind of like the acute on chronic process. So that's diverticulitis. Often the result of sort of smooth muscle overactivity. Constipation is very common in a lot of these patients. Presentation can be asymptomatic or can be painless Haematochezia. They often say, oh, there was the toilet bowl was full of blood. Realistically, the toilet, like they probably didn't defecate that amount of blood, but it was probably just a few drops of blood and that sustained the whole toilet bowl. But yeah, that's generally the presentation. Generally larger volumes with diverticular disease. And then in terms of treatment, so little things like increasing dietary fiber, so maybe giving them, so telling them to eat more veggies, less processed foods and less meat, maybe putting them on a supplement like Metamucil, telling them to increase water in their diet. So all these things kind of expand the volume of the stools so they can activate the stretched receptors in the colon, allowing it to pass through a little bit better. Medical management, you generally don't need antibiotics unless it's kind of severe diverticulitis. If they've got like a surgical is very rare, well, not very rare, but it's not really first line management at all. If they've got like an abscess formation, that might need to be drained. And if someone gets lots and lots and lots of diverticulitis, they might elect to have part of their bowel removed. That's causing the problem. Okay, so moving on to inflammatory bowel disease. If you're writing or typing, this is a really important slide. One of my pathology lecturers gave me this definition. I think it's a really good, succinct definition that ties in a lot of the components of inflammatory bowel disease in one. You have Crohn's and you have ulcerative colitis. So with Crohn's, it's a discontinuous process, okay? So it affects skip lesions or segmental parts of the bowel. Granulomatosis, so it has granulomas, which are just a collection of, it's called epithelial histiocytes. They're just a certain sign a pathological sign that's seen in a lot of inflammatory diseases. Transmural, so it passes through the muscle layer, it goes right down to the depth of the bowel, and it involves the entire GIT from the mouth to the anus. UC is pretty much the reverse. So really important definitions to get down. Okay, there are some pictures which kind of explain what I just talked about. But yeah, so you can see with Crohn's disease, so skip lesions and that transmural inflammation. So obviously, as a result of that transmural inflammation, you're more likely to have fissures and the sort of perianal presentations as well. And yeah, ulcerative colitis generally starts at the rectum and starts working its way up the sigmoid and descending colon. Okay, hopefully this table works. I don't think it will. Okay, it didn't. That's all right. So location of the affected bowel, Crohn's disease can occur anywhere along the GIT. You can get aphthous ulcerations in the mouth. It's mostly the terminal ileum. What problem would you get associated with damage or inflammation of the terminal ileum? Malabsorption of B12. Yep, so they can have a B12 deficiency and associated neurological consequences with that. The rectum is usually spared, but yeah, it can pretty much be anywhere along the GIT, whereas ulcerative colitis starts in the rectum and works its way upwards. Continuity, we've talked about. Skip lesions versus continuous parts of the bowel. We've also talked about depth. Microscopic pathology, you get a cobblestone appearance on Crohn's disease. I'm not entirely sure of the pathophys, but I think it's like deep ulceration over time it leads to these sort of these crevices, and they get this creviced formation. So it gets like this cobblestone appearance, or lots of bits which are raised. Fibrosis and stricturing, which you can see in both. And yeah, those fistulas, which are the important bits. Ulcerative colitis is more that shallow ulceration, and you can get pseudopolyps. Anyone know why they're called pseudopolyps? Yeah, they're not cancer. Yeah, they're not polyps. Yeah, okay. So what are they then if they're not cancer and they're not polyps? Yeah, it's actually normal. It's actually what's left. It's actually like regeneration of normal parts of the bowel. And because everything's kind of been like, inflamed and sloughed off, these little parts of the bowel start to regenerate. So it looks like it's pathology, but it's actually just like what's remaining of normal tissue. So that's why it's called pseudopolyps. In terms of radiology, in advanced disease, you can get a string sign, which is pretty self-explanatory. It just has to do with stricturing. And an ulcerative colitis, you can get thumbprinting. And one of the complications is toxic dilatation, which we'll talk about now. Okay. So in terms of presentation, I'll just emphasize the important points because everything's already on there. The main sort of differentiator between ulcerative colitis and Crohn's disease is Haematochezia, so bloody diarrhea, often with mucus, and tenesmus. So tenesmus is the sensation of sort of incomplete defecation, often accompanied by like pain and straining and things like that as well. But both can sort of give you colicky abdominal pain. Crohn's, it can be a bit of a weird presentation depending on which part of the bowel it's affected. In terms of complications, this is really important. So perianal fissures and fistulas we've talked about, vitamin B12 deficiency to do with the terminal ileum. There are a few other things with Crohn's disease and ulcerative colitis as well. So you have a higher risk of malignancy relative to Crohn's disease, and you can also get what's called a toxic megacolon. There's also lots of extraintestinal manifestations. So primary sclerosing cholangitis and other electrolyte disturbances are very common with ulcerative colitis. It's really important to know these extraintestinal manifestations as well. A very easy exam question, very easy OSCE after the station question. So on skin, they can have two conditions called erythema nodosum and pyoderma gangrenosum. Often affects the eyes as well, like a lot of autoimmune conditions as well. Often rheumatoid arthritis, things like that can affect the eyes as well, like uveitis, iritis, and episcleritis. And anemia, depending on how much blood you've lost as well. So really important, take-home message. It's really important to know the complications and extraintestinal manifestations of both these diseases. Nice picture. Okay. Treatment is very complex. I wouldn't usually go through this, but I got a question last week, so I thought it'd be good to touch base on it a little bit. So I guess treatment has two aspects to it. The first aspect is treating acute flare-ups. Okay, so how can we reduce that inflammation, which is associated with acute flare-ups? The second part is like, because this is an autoimmune condition, how can we
sort of suppress or change how the immune system is working to affect the long-term progression of this disease, okay? So acute flare-ups and long-term sort of immunomodulation. So for Crohn's disease, generally you'd start with oral steroids for acute flare-ups. Highlighted down below in clinical trials, so Flagyl or metronidazole and ciprofloxacin. Some consultants do use it, and sometimes they're added to corticosteroids, but there's not much evidence to support they actually work. So that's for mild to moderate Crohn's disease. In severe Crohn's disease, you pretty much just change, I guess, the steroid to IV instead of oral. And then you can also add things like infliximab, which, as you can see on the left-hand side, is an immunomodulator. And you also might think about azathioprine, which is immunosuppressive agents as well. So this is for really severe chronic disease as well. So now you're starting to look at how can we affect the long-term progression of this disease. That's for Crohn's, and that's maintenance therapy as well. In terms of ulcerative colitis, sort of similar. They generally use a 5-ASA, so mesalamine, as mainstay of treatment for initiating therapy. You can also use oral steroids for acute sort of flare-ups as well. There's a big table with more information looking at that 5-ASA, so sulfasalazine is generally first line for Crohn's. And then maintenance therapy, it's more or less the same thing with Crohn's. So looking at immunomodulating agents and then infliximab, so like immunosuppressants as well. So this is just a bit of a question from an exam, the faculty released exams, but we'll talk through it. So there's an 18-year-old male who's presented with 3 days of history of increasing abdominal pain, bloody mucousy diarrhea and fever. He's recently returned from a short holiday to London and he's reported multiple similar episodes in the last 12 months and has complained of tiredness and weight loss. Okay. So what do we think this patient has? So what's the category, the broad category? Appendicitis, pancreatitis? Yeah, inflammatory bowel disease. Whether it's Crohn's or ulcerative colitis is difficult to say. Yes, he's had bloody diarrhea, but sometimes Crohn's can affect the large part of the bowel. So you'd probably say more likely to be ulcerative colitis, but it could very easily be both. Tiredness and weight loss could very easily be both. So it's some kind of inflammatory bowel disease. It's not, we can't really say for certain which inflammatory bowel disease it is. But what we can say is so he's had this sort of chronic disease for 12 months, but it's an acute flare-up. So generally with an acute flare-up, we'd use steroids for Crohn's and maybe something like sulfasalazine, that 5-ASA for ulcerative colitis. Sulfasalazine is not an option. So what we'd probably tend to use in this case is prednisolone or that oral steroids. The next question, anyone have an idea of what we might use or what the answer is? Yell it out when you know it. D? Any other suggestions? So what did you say? What letter before? D? No? So 5 days and he has feculent vomiting. Does that sound good? No, that's very bad. So it's what that feculent vomiting represents generally is large bowel obstruction. 5 days history of large bowel obstruction, not good. So what's and that's supported with the abdominal distension as well. So what it seems like in this case is from chronic inflammatory bowel disease, it's called a stricture. It's caused a large bowel obstruction. So you need to sort this out straight away. And a immunomodulating agent or even acute steroids is not going to cut it. You need to operate and remove that stricture. Otherwise, his bowel obstruction is just going to keep progressing. And it's already progressed for 5 days. So presumably they already would have tried oral steroids. Yeah, so it is a little bit difficult. But yeah, if you can just stick to acute flare-ups versus immunomodulators, you should be all right. So again, that's the definition. Crohn's, discontinuous granulomatous transmural, entire GIT. Ulcerative colitis, continuous, not granulomatous, mucosal colonic disease starting in the rectum and working its way up. Colorectal cancer, don't have to say too much about this, most of it's on the slides, but there are a few risk factors. So the ones you'd expect, increasing age, family history, obesity, FAP, which stands for familial adenomatous polyposis, and H and PCC. So hereditary non-polyposis colorectal cancer, also called Lynch syndrome. They're just sort of two genetic conditions which, studies have shown that there's an increased risk of developing colorectal cancer if you have those. The common presentation and the common buzzword is blood mixed in with stools. Okay? Something that's not up there is screening for colorectal cancer. So how do we screen for colorectal cancer? Yep, fecal occult blood test. And yeah, staging and investigations are on the slides. Okay, let's go through some questions. So have a go and yell them out when... I'm not sure. Answer? Pardon? Oh, K. I thought you said A. And I was like, what? K, yeah. Ulcerative colitis. Yeah. So mucosal ulceration, that superficial ulceration, rectum to transverse colon, working your way up. Excellent. Next questions. Next two questions. Let's try to move through this quickly. So what was the first one?
H.
Try again. So 34. Oh, hang on. Whoop. Wrong question. Did I skip some? No. Okay. Oh, sorry, I skipped a few on mine. Yep, so I got H and E. Sorry, I was just working off the wrong question. I was like, what? Yeah, H, so yeah, you're right. So perforated adenocarcinoma, we talked about pneumoperitoneum last week and rigidity. 40, this is a bit of a tricky one. I think it's E for two reasons. One, it doesn't fit anything else. I actually think this is gastroparesis. Okay, so she just has vomiting and this sort of vague abdominal pain. There's not enough there to suggest it's anything else. But the past medical history of diabetes and multiple sclerosis, which has a neurological component as well, is significant. So in diabetes, you can get two types of neuropathy: peripheral neuropathy and autonomic neuropathy. So an autonomic neuropathy is can contribute to bowel and bladder dysfunction, postural hypertension, erectile dysfunction, and in this case, gastroparesis. So it's essentially just delayed gastric emptying. And that's why I think it's gastric outlet obstruction or gastroparesis. I think that they've specifically gone out of their way to mention she has a past medical history of diabetes and MS. So that's why I think it's gastroparesis. Next two. So what are the risk factors there for the small bowel obstruction? I guess appendicitis, yeah. So you could argue it could be small bowel obstruction. Yeah, I'm not sure. Could actually be small bowel obstruction. I think for me the diabetes was more significant, but I guess yeah, that is one you could sort of argue either way. Fair point. Let's have a look at the next two. Okay, so what condition does the patient in 44 have? So she's a type 1 diabetic. There's been a trigger of an acute viral illness. Hang on. So what's the condition that she has? What does she have, first of all? Not the answer, but what?
Acidosis.
Yeah, so it's a diabetic ketoacidosis, okay? So it's a metabolic acidosis to begin with, because the pH is 6.9. There's a low HCO3 minus as well. So it's a diabetic ketoacidosis, which is a cause of a metabolic acidosis. So the answer is generalized vague abdominal pain and fatigue as well. Probably wouldn't be projectile vomiting. That's more like pyloric obstruction. 45?
So you really have to know your anatomy about this. So this is a bit of a tricky one. Lesser sac. Pardon? No? Anyone else? Just yell at an answer. Have a guess. Not quite. Okay, this answer is actually jaundice. This is a very difficult question. If you sort of have a look at the images, the portal triad, which contains the bile duct, is actually in close proximity to the lesser sac. So these are two pretty difficult questions.
With the pseudocysts you get with pancreatitis, are they palpable?
Palpable, I'm not sure. They'd have to be pretty large to compress other structures, I'd say.
The DKA won't be hyperventilation, but what's it hypo?
It's generally hyperventilation. Yeah. Any ideas? Yep. Okay. So often with removing part of the bowel, you can often lose a lot of fluid from that procedure. Poor urine output and poor blood pressure. Yeah. So the simple thing to do is give them more fluid. Yell at that when you know. Offensive, bulky, oily, and difficult to flush, steatorrhea. Pancreatic insufficiency, good.
Okay.
Yep, small bowel obstruction. So remember, long history of constipation, we talked about with diverticular disease. Painless bleeding, burgundy, because it's not frank blood, but it has been in the bowel for a little while.
What's significant
Constipation. So it's more likely to cause micro trauma to the bowel, so to form those outpouchings, because it's due to colonic overactivity. That's why you get those outpouchings. Okay, so first one, good, acute appendicitis. Next one. Okay, second question. D, good. So, yeah, stools are often black and sticky. Loss of weight in an exam setting, think of cancer pretty much straight away. She's got melena, loss of appetite, loss of weight, and worsening abdominal pain. Okay, so question EMQ 37 is appendicitis. You've got rebound tenderness over McBurney's point. So it's irritation of what? What peritoneum? Parietal, yeah, because that's the one that has the innervation by an inflamed organ. And 38? 38? E, good, excellent, Eva. Retroperitoneal bleeding. He's already on anticoagulation, so that's going to exacerbate any bleeding that's occurring. He's got a poor, he's tachycardic and hypotensive, okay, which is classic signs of bleeding. All right, any questions with those? Okay. Because we're running short of time and these are a little bit tricky, this one, I might just go over this one. So they're the answers. So you don't need to know much of, what? Oh, okay. So yeah, so these ones, scrotal pathology isn't that taught very well. You don't need to know much about it. Okay, so what's significant here? So does anyone know what a saphenous is? So it's it's actually just a dilation of the saphenous vein. And this varix presents at the junction of the saphenous vein and the femoral vein, which is located in the groin. You remember where the femoral vein is. And it's frequently associated with chronic venous insufficiency or varicose veins, which is what's happening. And why does it disappear when he lies down? Because that's when you sort of remove gravity, so you don't have the pooling of blood in the bottom. The next one is a hydrocele, which is just an accumulation of serous fluid, particularly in the testes. The main thing here is, if you notice a difference, one of the differences between 42 and 43 is illumination, okay? So when you're doing examination of a lump, you might get your little light and see if you can shine over it and see if it passes through. Generally fluid, if something has fluid in it, it will illuminate. So just remember, hydrocele, you can illuminate it, or there's transilluminant. 43 pretty much tells you the answer. It's irreducible, it's not transluminant, so it's not fluid, and it's an inguinoscrotal swelling. So it's a indirect inguinal hernia. Also the fact that, yeah, sorry, that's it, indirect inguinal hernia, irreducible. Who agrees with him? Good. People with their hands up.
Isn't albumin long acting?
Pardon?
Isn't albumin doesn't take a long time?
Yeah. So pretty much you have when you're giving when you're resuscitating someone, you can give them crystalloid fluids like saline, Hartmann's, all that, or you can give them colloid fluids, albumin. The reason you probably give this person albumin, he's already in severe cirrhosis, hypotensive. He's got creps in the lung bases, and his albumin is very low. So the logical step is to replace his albumin. If you just sort of address the fluid, you're not actually addressing sort of the vascular compartments and the shifts, if that makes sense. So here you just give him more albumin. Pardon? Cirrhosis. I think with chronic liver disease, you can get a macrocytic anemia. I'm not sure. I can't remember why, but you can. Potentially, yeah. That's more thrombocytopenia, but yeah, I can't remember. Renal function's normal.
So just a question, why is lump in inverted commas? What do you think that implies? Well, it implies it's not actually a lump, right? It's not like a hernia or anything, right? Any ideas for 70? H, good. Again, you've got to read the question. They're putting things in there for a reason, right? They've mentioned clopidogrel twice in the one question, right? And they've also mentioned a cardiologist, okay? So even just from those words, you know it's got to be something to do with blood, okay? And it's not a hemorrhage, it's not bleeding, but there's a lump, which is a hematoma, a collection of blood. So it's a resolving hematoma. There's no cough impulse, means it's, it's not going to be a hernia or it's not going to be a lump, right? Does that make sense? So it's just about finding the relevant parts in the question. I think that's to do with gangrene, I think, because I know emphysematous colitis is to do with necrotizing colitis. I think you have to look it up. I'm not sure. Anyone for 71? Any ideas? I, yep, secondary hemorrhage. Okay, so pretty much we talked about what are causes of lower GI bleeding. Colonoscopy is one of them. Secondary hemorrhage is 7 to 14 days after. So this happened on the 10th day. Okay, so it's a secondary hemorrhage. You either know this or you don't. So does anyone know what the prophylactic surgical antibiotics are? Pardon? H, yep, good. So penicillin, gentamicin, and metronidazole. So it presents with heartburn. I, yep, so what process is this? Bowel esophagus, good. Going from columnar epithelium to glandular epithelium. And this one I'll just tell you because of time. So this is a cholesterol stone. So with biliary stones, you can have cholesterol stones, and you can also have, pardon? So the main one, yeah, so you can have cholesterol, which is like it's often a single stone, and it's often large, and it's often waxy, and it can have an acoustic shadow as well. Okay, all right. 3 conditions in 3 sentences. So you don't need to know a lot about these conditions. It might be good to know about irritable bowel syndrome, but as long as you have a rough understanding of what it is, I think that's enough because they're not big conditions. So ischemic colitis is generally due to hypoperfusion. There are different theories about this. So some people say it's due to atrial fibrillation. It's often associated with atrial fibrillation. And sort of the stasis of blood in the atria can form a thrombus, and that thrombus can embolize. It can embolize to different places. If it embolizes to the SMA, you're going to get hypoperfusion of the bowel. Other people just say it's just due to poor cardiac output. But yeah, hypoperfusion, and you're going to get severe pain because ischemic pain is severe pain. You can also get diarrhea and haematochezia. Colonic angioplasia is essentially often with age, degeneration of previously healthy blood vessels, and irritable bowel syndrome. So they can have fluctuating diarrhea and constipation, often triggered by stress. It's thought to be due to food intolerances. There's a lot of research going into the FODMAP diet, FODMAP. You might have heard of that. And the thing is, there's no positive findings on investigation. Okay, so colonoscopy could be completely normal, but the patient is still symptomatic, generally irritable bowel syndrome. A few things on celiacs. It's an autoimmune condition due to reactivity to which substance? Yep, gluten or gliadin, which is the gluten protein. Presentation is above. Does anyone know there's an extraintestinal skin manifestation seen in celiacs? Okay. So it comes up in questions. It's called dermatitis herpetiformans. And it's just sort of, you get lots of blisters, which sort of fill with this watery fluid. Gold standard investigation for celiac disease.
Yep, biopsy, yep, good. So often gastroscopy with duodenal or jejunal biopsy. And what antibodies are seen in celiac disease? Excellent, whoever said that. Anti-transglutamase antibodies, there's a few other ones as well. Anti-transglutamase are the best ones, but there's a few other ones as well. Yep. So endomysial, is that what you mean? Yep. There's a few other ones as well. Reticulin gliadin, which is the gluten protein as well. But anti-transglutaminase, antibodies are the main ones. All right. In terms of diarrhea and constipation, information's there, but can we talk, anyone think of some non-GIT causes of constipation? Good. So remember, always think about endocrine and gynae with gastro. So hypothyroidism, anything else? Potentially, I guess, yeah. Pardon? Yeah, lots of medications. That's a big one. So as above, remember hypercalcemia. So remember that combination of polyuria and constipation. It's a very unusual it's a very unusual combination, not constipation. And thanks for the laugh. There's like depression, drugs, and thyroid disorder as well. Lots of drugs can cause constipation. You don't need to know all of them, but they're some of the big ones. Has anyone heard of, there's lots of opioids that can do it. There's a drug called Targen, which is oxycodone and naloxone. And naloxone has the sort of stool softening property as well. So it's often good to give someone with pain. Diarrhea, often associated with these electrolyte disturbances, hypokalemia, a normal anion gap metabolic acidosis, and loss of fluid and loss of salt. That's the Bristol stool chart. It's just a way of classifying the consistency of someone's stool, so it's easy to give them a chart. So in your OSCE, it's always good to mention, I would get the patient to look at a Bristol stool chart and tell me about the consistency of their stools. Okay, so there's classification. So we can group it on inflammatory causes. So inflammatory bowel disease, malignancy. Generally, the questions you'll ask are to do with malignancy. So loss of appetite, loss of weight, night sweats, that sort of thing. Secretory causes are the ones I'm really going to focus on in the next slide. So these are all the infectious ones. And it's because the toxins have a sort of secretory effect. So they're secreting more water than you're reabsorbing into the lumen. So questions to ask are sort of general infectious questions. Have you been in contact with sick individuals, overseas travel, contaminated food and water, that sort of thing. Osmotic. So this can be due to a laxative. So you've got these substances which stay in the bowel, can't be absorbed, and they just draw water into the bowel. So it could be a laxative, or it could be a lactose intolerance problem. Questions to ask, are you taking laxatives? Does this happen, particularly when after drinking milk and those sort of things? Malabsorption. So the main one you're asking for is steatorrhea. Altered intestinal motility. So you can ask about thyroid sort of symptoms and those sort of things. And pseudomembranous colitis. What's the one important question to ask there? Excellent. Recent cause of antibiotics is cause of pseudomembranous colitis. Okay. All right. Let's go into some buzzwords. So what's the most common cause of gastroenteritis in children? Rotavirus. Good. What's the other major viral etiology? We usually see vomiting more than diarrhea. Norovirus. Good. The next three are all the same bug. So often after consumption of unpasteurized milk, birds are carriers. And Guillain-Barré syndrome is actually a rare sequelae of this. Campylobacter jejuni. Good. Poorly cooked chicken. Salmonella. Good. Rose spots on the upper abdomen and flu-like symptoms. No, not cholera. Salmonella typhoid fever. Okay, you might have heard of typhoid Mary. Shigella. Oh, hang on, crap, that's the next one. Yeah, so this is a bit of an interesting one. So men that have sex with other men, it's a bit of a stretch, but there tend to be, obviously there's a higher risk of HIV in MSM populations. And for some reason, there seems to be some reduced immunity, particularly to Shigella. So there you go. And organisms that can cause bloody diarrhea. Chest is the mnemonic I have. So it stands for Campylobacter jejuni.
The H stands for EHEC, so enterohemorrhagic E. coli. It's a type of E. coli. E is for Entamoeba histolytica, S for Salmonella, and S for Shigella. Okay, so they're the 5 organisms that can cause bloody diarrhea. Campylobacter jejuni, EHEC, enterohemorrhagic E. coli, Entamoeba histolytica, Shigella, Salmonella. Violent vomiting 2 to 6 hours after eating custard and cream, Staph aureus. So generally the toxins will give you instant vomiting. Bacillus cereus. Okay, so oh crap, I'm saying this. Diarrhea after eating some dodgy fried rice. Insufficiently heated canned food.
Clostridium?
Yep, Clostridium botulinum. The botulinum toxin. Gas gangrene. Another Clostridium. Perfringens. The next 3 are all the same. I'll just put this up. So now we're moving on to the protists. So cysts in stool, green frothy diarrhea, traveller returning from St. Petersburg. This has to do with, in St. Petersburg, a long time ago, there was an outbreak of Giardia in the water. Don't ask.
So how long ago?
Oh, I have no idea. Look it up. Amoebobiasis, a specific sign. And then cryptosporidium is actually something important. It's one of the weird and wonderful ones that you see in HIV and immunocompromised patients as well. Very important to know those. Okay, so treatment of diarrhea. Treatment of diarrhea. So the main thing here is usually all they need is fluid and rest. Okay, antibiotics are very rarely prescribed, and you should be careful of over prescribing them. The rectum and the anus. Okay, so with the rectum and the anus, talking about painful perianal conditions, there's lots of them. Hemorrhoids are probably the most important and one of the most common ones you'll see. So there's 4 grades. So with grade 1, they generally bleed but don't prolapse. 2nd grade, so if grade 1 was not prolapse, 2nd grade would prolapse. But they're spontaneously reducible, okay? So they'll come out and then they'll go back in. Grade 3, they prolapse and they require manual reduction, whereas grade 4 is their thrombosed hemorrhoids as well. And that influences management as well. Abdominal pain, there's my differential list for abdominal pain. You can read it over in your own time. And how to do a GIT exam, which hopefully you're all getting good at by now. If not, start getting good at it, because Huskies will be here before you know it. And we'll just go through a few questions to finish. Yell it out when you know it.
Inefficient.
Pardon? Sorry, I didn't hear that. What did someone say?
Someone said E. No, I said A.
Okay, it's G. Okay, so the reason it's hemorrhoids, sometimes they're not painful. The reason it's not anal fissure is anal fissures are excruciatingly painful. And bright red bleeding per rectum is very characteristic of hemorrhoids. Yeah, and hemorrhoids you don't feel on a digital rectal exam, okay? Unless they're like thrombosed and prolapsed, but if they're normal, you wouldn't feel them.
Wait, so they're large enough to bleed, but not large enough to feel?
It's not necessarily large enough. It's more to do with the vascular supply with the hemorrhoids. The next 2. So past history of ischemic stroke. Any louder? F, yep, good. So we're looking at cardiovascular risk factors and also elevated lactate. So lactate dehydrogenase is an indicator of, I think, cell turnover, but it can also be cell necrosis and breakdown as well. And the last one? G. Okay, yeah. So it could be small bowel obstruction, but the better answer is an incarcerated hernia causing a small bowel obstruction. The reason you pick G is because they've specifically mentioned mildly tender lump in his right groin. So it's the better answer out of incarcerated hernia and small bowel obstruction. Does that make sense? Yeah, we talked about bird droppings. Also lives on a dairy farm, so the milk is not always pasteurized. Now just remember which one it is. Anyone? Campylobacter? Okay. Chicken. Gets easy, doesn't it? $25? Pardon? Yep. Cancer. And 26? So burning pain on defecation?
Fisher.
Yep, anal fissure. What is the ointment that was probably prescribed that's causing severe headaches?
Like trinitrate.
Exactly. GTN. Okay. Common side effect is headaches. You often see that in patients with angina as well. Trophocytes. A bit hard. Okay, so it's entamoeba. So it's literally one word gives you the answer. Pardon? Which one?
M.
I haven't got a clue. I'm not. Never heard of it. Tissue transglutamase, bloating. Okay, so these are just a few taken from Syed's. So Syed is his name, S-Y-E-D. His book is called EMQs in Clinical Medicine. Fantastic book. Would highly recommend everyone gets it from the library or buys it, because it's probably going to be gone from the library after I've just said that. But there's a few questions there. You can go and have a look. Excellent questions. Thanks very much for coming. All the best with third year. I've got to run off, but if you have any questions, feel free to Facebook me.
And thank you to the seductive and sensual King Julien for that amazing lecture. To all those at home, good luck and Godspeed.